So yeah, it's Sophie that is moderating now. And Dr. Sophie Collins. She is a post-doctoral researcher at McGill University. And I'll let her moderate this session. So Sophie, the floor is yours.
Thanks, Felix. All right, so our first presenter is Dr. Nicolle Domnik from Queen's University, and she will be presenting on evaluating metronome-paced hyperpnea as a method for inducing dynamic hyperinflation and dyspnea in COPD. So Felix, if you can grant her the rights to share, please take it away. So you have 5 to 6 minutes to talk. If you go over, I will give you a warning. And then we'll have about 11 to 12 minutes for discussion afterwards. Perfect. We can see your slides.
And I think I'm trying to figure out how I can see the chat here. That's always my, my drama with Zoom. I was like, how do I see the chat while also online? Not that way. All right, well, I will say if I do, oh, there we go. If I do go over, you can just unceremoniously punch me offline and I will, yeah, I will take that in good stride. So thank you so much, everyone. I think actually in some ways this may not answer a question that was posed earlier this morning by Dr. Jensen when he was saying, we have all these different assessment modalities from the MMRC all the way through the spectrum to CPET. And so I think what I'm presenting today is a sort of it's crossing the line from a proposal to a nascent investigation that we're doing here, trying to investigate one other potential assessment tool that might fit into this arsenal of tools here. So as a quick refresher, when we think about ways of evaluating dyspnea and evaluating also functional performance, one of the things that often comes to mind is the assessment of dynamic hyperinflation, often in the context of exercise in individuals with obstructive disease. And so this is again where you have incomplete exhalation preceding the next breath, leading to air trapping, reducing inspiratory capacity, ultimately causing changes in breathing mechanics, increasing work of breathing, but also I think with particular relevance to today, contributing to symptoms like dyspnea. And ultimately, it's that constellation of symptoms and physiologic changes that can also lead to things like exercise intolerance. And typically, when we think about the evaluation of dynamic hyperinflation and dyspnea, it's often in the context of things like cardiopulmonary exercise testing or exertional dyspnea. And so while CPET is one of the sort of gold standard approaches for assessing dynamic hyperinflation, it does have some limitations. Some of these are practical in nature, both the time and personnel and financial cost of performing more complex testing, time consuming also for participants or patients who are coming in. And I think especially of relevance to the conversations that we've been having so far today, there's also a burden associated with this in terms of the resource burden needed to offer this kind of testing, but also the burden to participants in terms of whether it is accessible to them at all, especially in conditions or in individuals with comorbidities that might impact on mobility or balance. This might not actually be a testing method that is accessible to them. And so one of the questions that has been asked is, could there be a surrogate test or an alternative way for inducing dynamic hyperinflation and symptoms like dyspnea that would help overcome some of these limitations in settings where CPET might not be viable? And so one such protocol that's been proposed is the idea of metronome-paced tachypnea, or MPT, which is essentially a voluntary breathing maneuver where a participant or a patient would be asked to breathe at a high frequency for a period of time. Typically, this is at 40 breaths per minute, guided by metronome. And the idea is that this would mimic the ventilatory stresses that you would see in something like exercise without actually requiring physical activity. And sort of proponents of this approach have suggested that it could be a lower burden, non-exercise based alternative to CPET in terms of inducing both dynamic hyperinflation and dyspnea. And it's also been proposed sort of in addition to that, that this could therefore be a lower burden or easier means of assessing bronchodilator responses or therapeutic responses in obstructive lung disease in terms of seeing what their impact is on propensity for dynamic hyperinflation. So to give you a little bit more of a concrete context in terms of what might one of these MPT protocols look like, this is a timeline that was taken from a paper by Cooper in 2023. And you can see that there are periods of resting breathing, both through baseline and then recovery intervals lasting about 2 minutes, interspersed with 30-second breathing periods where the individual is breathing at a higher frequency of 40 breaths per minute. And those are all flanked by inspiratory capacity maneuvers. And so the idea is that for each of these discrete 30-second periods, you can evaluate whether or not dynamic hyperinflation has occurred, and if so, of what magnitude, and then also across the multiple iterations of those fast breathing periods. Is it reproducible? Is it not? Does it stack over time? Does it not? So this is a typical timeline that has been proposed for both inducing and then evaluating dynamic hyperinflation without the need for exercise. That said, there are some knowledge gaps. And these largely concern the idea that MPT may not reflect some of the key physiologic considerations that are present during exercise, but not at rest, that might be relevant to assessing dynamic hyperinflation and symptoms. So whether it's not having a pattern of breathing that matches the hyperpnea that you'd see in exercise, most protocols just focus on respiratory rate, not on volume or depth. The possibility for hyperventilation to result in hypocapnia and thus maybe cause changes in airway tone. But even in terms of not having great characterization of sensory responses to these types of voluntary protocols, which may not reflect the integrative sort of components of exercise, and again, whether or not these can actually assess bronchodilatory effects. So the aims of our current project are to evaluate, compare an existing versus a novel MPT protocol in comparison to both physiologic and perceptual responses to exercise testing. And so to this end, we developed a novel protocol that we're calling MPH, or Metronome-Paced Hyperpnea for now, where it's not only a matter of targeting a certain breathing frequency, but also a targeted and unique volume targeted to that particular patient or individual, inspiratory-expiratory ratio, and also adjusting inspired gases to try to prevent the onset of hypocapnia during these tests. And so we're going to compare traditional versus our variation on these paced breathing protocols versus exercise, and look at how that impacts on ability to induce hyperinflation to begin with, characterize dyspnea responses, and assess bronchodilation. And that's going to occur through a 3-visit study where at visit 1, individuals will perform both of the paced breathing protocols and an incremental CPET to symptom limitation. And then randomized at visits 2 and 3, they'll either receive bronchodilator or placebo, and they'll undergo, once again, both paced breathing protocols, but also a constant work rate exercise test to allow comparison for the 3 different conditions of exercise and the 2 paced breathing protocols. And this is going to be undertaken in individuals with COPD and to start for a pilot with resting baseline hyperinflation as well. So I think I'm still in time, but with that, I'd like to say thanks to everyone on the team. And a special thank you to Dr. Matthew James, Reggie Smith, and also our current summer student, Renusha Parandapan, who's really been sort of driving a lot of the charge on this over the summer to get things going. So yeah, thanks very much, and happy to take any questions.
Wonderful. Thank you, Dr. Domnik. I'm just looking here to see if we have any questions, and I'm not seeing any hands popping up. So I guess I will start. Oh, Felix, actually, I just see his hand going.
Sorry, it's I think it's Dr. Benzet that rose his hand, so I'll give him the floor. Just give me a second. There we go. Okay. Dr. Benzet, you can ask your question.
Hi, can you hear me?
Yes.
Crystal clear.
Good. First of all, I think this is a really interesting idea that's got potential. The one issue is that hyperventilation will lower PCO2 and maybe, depending on the patient, raise oxygen a little bit. And so you're reducing the air hunger stimulus, which is a big part of what goes on in exercise in these patients.
Absolutely.
You could manipulate inspired gases to actually raise CO2. I don't know if you want to lower oxygen in these people, but you could actually raise CO2 along with hyperventilation, and that would bring you closer. It still doesn't get the muscle receptors and the locomotory centers and all that kind of stuff that feeds into exercise hyperpnea, but it would get you closer.
Yeah, absolutely. So I appreciate that comment a lot, and that actually is sort of is a little bit heartening because that's one of the things that we have been doing. So One of the changes that we did make, because we were concerned about the potential for the development of either hypocapnia or even just thinking about maintenance, was that we initially looked into whether we could get a sort of responsive breath-by-breath circuit, and that got very complicated very fast. So as part of this pilot, what we're doing is we're sort of bleeding in during those periods of hyperpnea only, so not during the resting breathing in between. We're having the individual do those hyperpnea periods from a mixture of 5% CO2. We figured it would be sort of err on the side of caution and sort of have that be a constant for everybody rather than risking a loss of CO2. And we are monitoring transcutaneous CO2 as well as end-tidal CO2 during those protocols. So we're curious to see how that, in the first couple of participants coming through, whether or not that 5% inspired CO2 is sufficient to kind of maintain at least an isocapnic environment. And then we'll sort of adjust our protocol or titer from that. But that's yeah, like I said, I really appreciate hearing that we're on the right track with that to try to at least somewhat control for that.
Yeah, but can you still hear me?
Yeah, please.
Yeah, but you could actually raise CO2. I think that's probably an important part of this. Increased drive to breathe is an important increased involuntary, increased brainstem drive to breathe is an important part of the dyspnea during exercise. And CO2 is really safe to use. I recommend everybody look at Fruman's paper from the 50s. But more than that, we have a lot of experience with that, including in COPD patients. Oxygen is more dicey, but I think they both essentially result in the same sensation, according to Shakib Mousavi's work when he was with us. So I would encourage you to experiment with that next.
Okay, that's fantastic. I've got my notepad and I will look forward to doing so. Thank you.
Thank you.
Do we have any other questions? No, it doesn't look like it. So I was curious, how are you identifying your tidal volume targets?
Yeah, so we went back and forth around this. And so what we ultimately settled on was going sort of based as a percentage of that individual person's inspiratory capacity. So thinking back to how once people sort of reach dynamic inspiratory constraints or inspiratory limitation during exercise, how that often leads to both a change in breathing pattern, but also a sort of an uptick in symptoms. So that's what we were using as our yardstick for targeting IC in a more patient-specific way. So rather than saying, here's an overt lung volume or lung volume per size, but actually targeting that to the resting inspiratory capacity of that individual when they come in for testing.
Great, and I see Dr. Jensen's hand is popping up. Go ahead.
Yeah, hi, Nicolle.
Greetings.
Hi, Nicolle. Nice presentation. I'm just kind of building a little bit on Dr. Benzet's important comment. There's been quite a bit of work on the nature and the source of kind of ventilatory stimulation. And I mean, anecdotally, if you take a person with COPD or ILD and you get them to voluntary hyperventilate or do an MVV maneuver, or if you take an asthmatic and get them to do an EVH, which is like 6 minutes of breathing at 85%, they don't experience breathlessness. They might, it's not a cult breathlessness like they experience. And so I question whether or not a dynamic, metronome-paced hyperventilation, whether it's isocapnic or, is really going to get at what you're looking for as a simple test. I mean, I would argue that a 3-minute stair stepping test would be much better to do something or than that. I don't, not to be a super critic, but I don't know how a voluntary hyperpnea test is going to give you dyspnea that mimics exercise, and I certainly hope it does. Bleeding in carbon dioxide into the system is not really going to get kind of like what you want in terms of a simple test, because that's going to add a technical layer. I wonder, as maybe a more facilitatory comment, is what if you just had people, and there's a little bit of evidence for this in your design, what if you have them do voluntary breath holds and see whether or not there's a correlation between the amount of time that somebody can hold their breath and the level of tolerance and the level of dyspnea that they experience. I mean, they would develop, some mild asphyxia. You could, get some of the state trait anxiety, the provocation and things, and see whether or not that correlates. That's something that I've been thinking of for about 15, 20 years. We've never done it in COPD, but it looks like something that you could maybe easily implement into your protocol with a minor amendment. And asking somebody to hold their breath in a clinical setting would be much easier than making them hyperventilate and needing, spirograms and pneumotachs and, and all of this to measure hyperinflation and so on and so forth.
That's awesome. Thank you. So full disclosure, and at risk of sounding like I'm trying to aggressively self-critique my own protocol, and not that I'm necessarily hoping for a negative outcome, but I'm actually part of the reason that I wanted to undertake this study was because I was reading through a solid handful of papers that were all suggesting that beyond inducing dynamic hyperinflation, that this could be a good way to mirror dyspneic responses. And every time I read that, my thought was, really? And so I'm actually quite skeptical if it will. And so in a strange sort of way, I think part of my motivation for pursuing this would be because no one's really actually quantified that, to be able to say a little bit more definitively maybe, or have some evidence towards, actually, I don't know if it will. So I'm really curious to see what the dynamic hyperinflation profile looks like. And then if that actually does, as I sort of suspect that it will, deviate away from the symptomatic responses, because I totally agree with you. I think in most cases, regardless of what the voluntary maneuver is, it doesn't induce the same type of symptom that you would see through something else. And so I'm actually really excited to see if there isn't a negative finding there, because I am very unconvinced that there will be effective induction of dyspnea from the protocol as proposed. But I think that information alone will be helpful, given that there's been speculation about its utility in this realm, but not actually anything sort of that I've seen, at least, that sort of substantiated that it can do it. So I'm really curious to see what shakes out of this. My suspicion is that we will not get a dyspnea response of any particular magnitude, especially compared to CPET. But I think that finding alone, I would actually be really intrigued to see.
Sounds good. Thanks.
Yeah, thank you.
Thanks so much, Dr. Domnik. I think it'll be really valuable to see these results, especially with some of the larger cohorts using some similar methodologies now. So great. Thank you. So we're going to move on to Dr. Meena Kalluri from the University of Alberta. She will be presenting her project on the inevitability and invisibility of breathlessness, perceptions and barriers to management in ILD. So when you're ready, take it away.
Thank you so much. I'm delighted to be here. I just found out about the conference through one of my friends. So I was super excited and so glad that you were able to accommodate me into your conference. So with that, a very good morning to everybody. I am an interstitial lung disease specialist and happy to discuss the results of our qualitative study. So most clinicians know that breathlessness is actually quite prevalent and a very distressing symptom in ILD. And despite multiple guidelines over the past decade, in clinical practice, breathlessness, even though it's one of the most common symptoms in ILD, is not consistently or systematically assessed by healthcare professionals, all the way from physicians down to other allied staff and nurses in the clinical setting. So the aim of our study was really to explore the visibility, the perceptions of visibility of breathlessness, and some of the common challenges that healthcare professionals face when they're looking after patients with ILD. And we used a qualitative inductive approach using focus groups and key informant interviews. So we were fortunate enough to recruit about 28 healthcare professionals who were experienced in ILD patients across practice settings. Some of them came from clinics, hospitals, home care, so community settings, and participated in rehab programs. We included some generalists as well as 17 specialists who exclusively managed ILD patients. And they came from about 6 different disciplines or roles, including respirologists, palliative care clinicians, nurses, nurse practitioners, physiotherapists, respiratory therapists from 4 different countries across North America as well as Europe, as listed here. So essentially, what we discovered is that this theme of inevitability and invisibility was central and the most dominant perception through all of these different healthcare providers, as exemplified by this quote. This is a healthcare professional who's saying, well, if you have a lung disease, so it's expected, you're going to be short of breath, and in that it becomes invisible. Well, we can't do anything about it. And I think that's so central to experiences, not just with ILD healthcare providers, but also is quite pervasive across different disease groups, regardless of what the source of the disease might be, whether it's breathlessness from COPD or other types of lung disease, or even the non-pulmonary conditions where you have breathlessness. Most clinicians appear to lack competency or confidence in symptom management. So there is this assumption and acceptance that we can't do anything about it. And in that, it becomes both inevitable and invisible. So it's not that it's literally invisible, but it becomes invisible simply because they accept it as part and parcel of the disease process. The other is, in contrast, we had another healthcare provider who basically challenged that perception, and they said, this is the most important thing for healthcare professionals to know for patients with ILD, and it is their responsibility to help them with breathlessness. And they exhorted the other providers not to ignore it, suggesting that once you have confidence in managing and in assessing breathlessness, as this provider did allude to, they recognize that it is neither inevitable nor invisible. And once the healthcare providers assume that sense of responsibility, then it is possible to challenge that perception. The other themes that we discovered in our project that help explain why this perception of invisibility persists is because a lot of these patients, as they get breathless, they adapt. They learn to live with their disease. They start to pace, they use oxygen sometimes, they use other breathing techniques, manage their anxiety, and seemingly present as quote unquote normal. And this is also quite common across other conditions and not just specific to ILD, where patients are asked generic questions like, are you breathless? How do you feel? How are you? And typically they respond by saying, quote unquote, I'm fine. And the other problem is most of these patients, when they're examined in clinics in my country, and I'm sure across the world, they're usually in a seated position. Or even in a hospital, they're laying down in their hospital bed. So they're at rest. And very typically in ILD, earlier on, the disease presents with exertional breathlessness. So they look very comfortable at rest, which can be very misleading in the clinical situation when you're assessing these patients. And the breathlessness becomes visible only with exertion and or disease progression. So that's the reason the providers felt that a lot of times these factors contribute to the invisibility of breathlessness. In addition, they also highlighted that the breathlessness assessment by itself in the clinical context appears to be quite complex, namely because when you ask generic questions and you're not using a proper dedicated tool, then it becomes difficult to uncover breathlessness. And you really have to probe the patients. You have to probe about their activities, about their daily life, and uncover this. One of the other fascinating things that we discovered was this dichotomy that many of the providers faced. And sometimes the dichotomy came from their roles. So for example, a respirologist, when they're assessing breathlessness, they were keyed more into, should I make a diagnosis? What's the etiology? What's the disease? What's the disease severity? Rather than looking at ameliorating the symptoms or thinking of symptoms as targets for intervention simultaneously. The other dichotomy came when patients are in acute distress and you're focused on alluding or figuring out what the etiology is, and rather than trying to simultaneously manage their symptoms at the same time. So this dichotomy was perceived in many situations, and sometimes also in chronic breathlessness, where it may not necessarily pan out to the patient's benefit. The other issue was in most clinic settings, we use objective testing. There's a lot of reliance on PFTs, and there is understanding that the subjective symptom can also be assessed through objective lens, and our providers came out very strongly and clearly recognizing that that's obviously not possible. Sometimes you have normal pulse oximetry readings and the patients are still complaining of breathlessness. So they also alluded to the fact that this can happen. So reliance on objective lens is probably not very useful for patients. And then eventually they all pointed out to the fact that there are validated tools for breathlessness, but the problem is in clinical world, it's very difficult to integrate some of these tools simply because of the administrative burden it places on the clinic staff as well as on the patients. So numerous studies that have been published in the last decade or so have highlighted that most commonly used breathlessness measures such as the MRC or the NYHA or just the Borg score may not be comprehensive, but they tend to be used for just ease of use and familiarity. And surprisingly, and actually quite shockingly, across the country and across disciplines, most of the providers in this study acknowledged not being prepared and not knowing about breathlessness through their initial education. And they all reported that they learned how to assess breathlessness, became confident in managing it only through engaged and experiential learning. And the only exception on that front were two clinicians who undertook formal training. So their formal training in palliative medicine allowed them to become a little bit more confident in managing breathlessness. Otherwise, all of these providers right across the board, from pulmonary critical care specialists to palliative care medicine specialists to allied health, nursing practitioners, they recognize that breathlessness is not actually prioritized in education. So just to conclude, breathlessness is missed, hidden, ignored, and sometimes normalized by healthcare providers, patients themselves who are quite stoic at times, their families and friends who may not obviously know that patients are breathless simply because breathlessness is not always present at rest. And this is a missed opportunity because it leads to poor care and a loss of quality of life. And therefore, we believe that we need to prioritize systematic assessment of breathlessness to uncover it in ILD. The assessment, no doubt, is complex, simply because a generic question or a simple question like, are you breathless, rate your severity alone may not be sufficient to uncover the nuances of breathlessness in ILD, particularly because it affects daily life and daily activities. And therefore, our providers were explicitly asking for probing of breathlessness severity with specific activities as directed by the patient's context. They also highlighted the need for an easy to use tool that allows them to not only assess breathlessness, but actually help in management, for which there's no evidence that any of the existing prompts have actually improved or changed management of dyspnea in clinical practice. And finally, they shared that experiential learning and mentorship with expert clinicians is what enhanced their own level of confidence and may in fact be the way forward for us rather than just didactic learning on symptom-based education, which seems to be what's happening in medical education in my country and perhaps even throughout the world. So I'll stop there and just thank you all for your time and attention. And I'm happy to take any questions or any feedback that you may have.
Wonderful. Thank you, Dr. Kalluri. Do we have anyone with questions? I don't see anyone, but Felix, let me know if I'm wrong.
Yeah, so we have Dr. Musavi with a question. So I'll give him the mic. You can, yeah.
Hi. Thanks for that perspective. I just wanted to raise one question about the assessment tools, because one of the reasons why the Dyspnea 12 was developed was precisely for some of the problems that you've raised. And I just wondered whether you'd had a go at using that, because it's based on the language that patients use, including ILD patients, to describe their usual breathlessness. So it's not when they're at rest, but their usual breathlessness. And it's multidimensional. So it does extract some of the things that can be missed if you just use an intensity scale. So I was just wondering whether you'd used that and whether you thought what you thought of it. And also wanted to point out that in terms of ease of use, it's very minimal. So there's 12 core descriptors, which can be completed using a Likert scale within a minute. And it doesn't require any additional instruction from the healthcare workers for the patients. So I just wondered what you thought of that tool.
Thank you for that question. So we did ask all of the healthcare providers who were interviewed for this study to share their experience. And they did recall, and I recall them mentioning some of these tools, including Dyspnea 12. But it's quite strange that in spite of knowledge that there are validated tools and seemingly there is data to show that it's quite simple and doesn't take that much time, I think the problem is more or less prioritization, and clinicians have, even though they have knowledge of these validated tools, they are choosing to use something as simple as the MRC rather than using either Dyspnea 12, or there's MDP that can be used in specific contexts. And there are specific tools that are already validated, in fact, recommended in ILD. So my sense is that they know about these tools, but somehow because it's not prevalent in practice, so they're not seeing other clinicians use it, they're not using it themselves. And the people that we interviewed were actually at ILD centers. So I would assume that all of them are aware of it. They mentioned some of these tools, but they still choose to use something similar or something simple like the MRC or the modified MRC rather than using any of the more advanced tools that are multidimensional and obviously better at assessing dyspnea. And this is why I feel that I think there needs to be more education on symptom management and more discussion around how do you assess in a very practical way. And that's what's missing in practice. And sometimes even if that's discussed in conferences, in rounds, and I've attended several of them, there is a gap between that knowledge and it being translated in clinical practice. And I think that's what we're seeing with a lot of these symptom management issues, assessment and management issues, that while the research is moving forward and it is showing us better ways of assessing symptoms, better ways of managing it, I think there's a big translation gap in practice.
Thank you.
Do we have any more questions? I don't see anything in the chat right now. Dr. Binks?
Can I just jump in? I just want to thank you for setting up my presentation tomorrow superbly. I think we're in full agreement about the education on dyspnea is woefully lacking in several arenas, and the Dyspnea Society has started that educational initiative to address some of the concerns you described this morning.
Thank you for doing that. I actually suppressed some of the slides because we were frankly stunned with some of the comments that we received from clinicians across the world. I'll just give you one instance. There was a clinician who said the only training they had about dyspnea in their initial education was to be quote unquote afraid of it. So this was prevalent across the board. And it became quite obvious. And sometimes it's shocking to me because as a pulmonologist, I feel like we need to own dyspnea. This is our thing. This is our domain. And yet it's quite unfortunate that even though we are quote unquote aware of the symptom as is, so it's not invisible in that sense, but it's not being managed well. It's not being seen as a target for intervention. And I think it's rooted in not having enough confidence in assessing and managing it. So when you don't have confidence, then you tend to ignore it and you push it by the wayside. And that's what's happening repeatedly, whether you look at COPD or ILD. And I think the focus really needs to be in improving dyspnea education. So if you're doing work on that, kudos, and I look forward to hearing more about it.
Great. We'll see you tomorrow morning. Thank you very much for your talk.
Thanks.
I think I saw Dr. Flannery pop up. So if you do have a question, go ahead. We have time for one more question. Maybe not. So I guess my question for you, Dr. Kalluri, before we move on to Dr. Aucoin, is whether you plan on doing patient interviews and then potentially doing some an implementation of your findings in practice.
Thank you for your question, Sophie. So this study is actually a part of a larger study where I'm validating a tool that I've specifically created, not just to assess dyspnea, but to deal with the second part of it. Like how do you manage it in clinic? Because in my understanding, there are no dyspnea prompts to this day, even though there are validated tools that are easy to use, they're multidimensional, they have shown no impact on clinical integration and particularly management of this really troubling symptom. So I wanted to see if we could create something that's, number one, easy to use and also helpful in management of patients besides assessing dyspnea. So I'm validating a tool that we have created and have been using in clinic. And as part of that study, we did this project where we interviewed healthcare providers, and we're also interviewing patients. So that study will be hopefully published in the next few months. And we will also be comparing and contrasting patient populations where the tool that's in question is used versus not, just to see if it has an impact on management and self-management in particular for patients. So stay tuned. We'll have something more on that. Thank you.
Looking forward to seeing that. Great. So we will move on. Thank you, Dr. Kalluri. We will move on to Dr. Rachelle Aucoin, newly minted PhD, working at Dalhousie as a research associate. And she will be presenting on the progression of lung function changes and respiratory symptoms in young adult e-cigarette users. This looks like it will be a protocol. So take it away, Dr. Aucoin.
Hi, everyone. Hi, Sophie. Thank you. Yeah, so like Sophie said, I'm working as a new research associate in the Faculty of Medicine at Dalhousie University, so located in Nova Scotia, Canada. And I'll go over a little bit over some work that we have done previously in e-cigarette users and a large project that we are proposing to run in this province. So based off of Canadian survey data, almost 50% of youth and young adults, so anywhere from 18 to about 25, in Canada have self-reported trying e-cigarettes, or what we colloquially call vaping, at least once in the last 30 days. And keep in mind that this is a self-report, which probably means that it's a little bit underreported and that people are probably vaping a lot more often than they want to admit. Without clear evidence-based guidelines and guidance from public health officials such as Health Canada or any provincial regulatory bodies, a lot of people believe that vaping is safer than tobacco cigarette smoking, but there really isn't any data to support that yet, and we don't really know what the long-term effects of electronic cigarettes are, especially on lung health. My team a few years ago, so this was before I arrived, they did do a small cross-sectional study, about 40 to 50 people in each group, where they were comparing lung clearance index, which is just a measure of ventilation homogeneity, and using the multiple breath washout test, and that specifically assesses damage or impairments in the small airways. And they saw that in people who were exposed to vaping, who self-reported as vapors, had much worse ventilation inhomogeneity, so a worse lung clearance index, as opposed to unexposed. And we can see that in heavy users, which is 5 puffs or more an hour, the difference was quite substantial. And just to note that some Nova Scotia survey data from last year supports that almost everyone who reports themselves as vapors are considered heavy vapors, so more than 5 puffs an hour. In this study, they also just looked at the presence of respiratory symptoms. They didn't quantify the severity or assess it during exertion, so this was just recall at rest. But e-cigarette users or vapors did report the presence of respiratory symptoms, and notably breathlessness was an important symptom that was recognized by this group. A little bit of other work in this field suggests that measures of lung mechanics via oscillometry are greater, as in it's worse, so higher lung resistance, higher lung reactance in people who vape as opposed to people who do not. When we look at an image of the lung using MRI, so specifically using pre-full MRI, which is a non-contrast free breathing technique, we can see that ventilation perfusion in the lung is impaired in people who vape, specifically in young people. And then amongst these studies, these e-cigarette users also report an increased presence and severity of respiratory symptoms, like I said, notably breathlessness, but also cough, mucus, and phlegm. But we don't really know kind of what the severity of this breathlessness is in this new population. Overall, we don't really understand the long-term effects of e-cigarette use on lung health, especially in young adults where their lungs are still evolving up to that 20 to 25-year range. And we can't really afford to wait decades to conclude whether e-cigarette use is harmful to the lungs. So what I'm proposing and what we're proposing here is a large study to first replicate our cross-sectional findings across 4 different groups. So e-cigarette users, dual users, compared with just commercial tobacco users, and then compared to healthy non-users. We're going to try to recruit 400 people in Nova Scotia. We're going to look at a young adult range. We're going to do a very wide array of detailed lung function testing. And importantly, I'm going to try to dive a little bit deeper into the presence and the severity of respiratory symptoms and breathlessness in these populations. Our second aim will be to quantify the longitudinal changes in lung function and respiratory symptoms at a 6-month follow-up and at a 12-month follow-up to see what the rate of change is. And then in more of an exploratory aim, we're going to look at a subset of participants who have successfully quit vaping. Not that this is a cessation study, but we just want to see the natural behavior of these people. And we're going to retest their respiratory symptoms and their lung functions to see if those changes or that damage is permanent or is it reversible. We really want to better understand how e-cigarettes affect lung health, especially respiratory symptoms and how they feel. And this is especially important in young adults. We're proposing a 1-year project because there really isn't any data looking at this yet. So we're going to start a little bit more conservatively. And our findings are directly going to inform provincial and national regulatory policies on e-cigarette use and cessation efforts. Thank you.
Very nice presentation. Thank you, Dr. Aucoin. So I'm just waiting to see if anyone pops up in the question in the chat. I don't see anyone. So I will go ahead and ask the first question while we're waiting. So this is an ambitious project, but with potential pretty meaningful implications. I do know that there are some cohorts down in the States that are doing some similar work, doing MRI and CT scans in vapors, non-vapors, and smokers and dual users. I do wonder whether you might be interested in doing some cardiopulmonary exercise testing, perhaps in a subset of participants to better look into the underlying mechanisms of dyspnea.
Yeah, it's something we're discussing. We are crafting the application and the protocol right now, so it's certainly something we're interested in. We've talked about doing just standardized exercise testing, like a 3-minute step test as well, just to assess their breathlessness. But certainly CPETs is something that we could incorporate as well. And to your earlier point with imaging happening in the States, that is something we're going to include in a subset. We have access to pre-full MRI at Dalhousie here, and we're working with our physicist, a radiology physicist, who's going to help us give a kind of a greater idea of what's happening in the lungs using imaging. So I think what we're thinking for the protocol is let's assess the lung function testing that we know, and hopefully we have the room and the budget and the time to add these more sensitive tests in.
Wonderful. Yeah, it's a very large undertaking. Congrats.
Thank you.
So I do see one question in the chat, and it says, what about carrier gas effects? And this is from Dr. Paul Davenport.
Could you just expand a little bit on what you mean by carrier gas?
Well, with the vaping, obviously there are additives that are added to it. So you have nicotine added to it or something like that. Well, one of the concerns has been the gas that when the vapor comes out, it has a carrier gas that brings. And so the carrier gas it's differentiating between the effect of the carrier gas itself or the additives itself, plus all the different flavorants that are added to that. I guess what I'm wondering is, in your studies, will you be able to maybe even test whether or not the carrier gas in the absence of the stimulant or some of the additives may have an effect in terms of pulmonary function?
Yeah, that's a great question. And we've talked a little bit about, the effects of like the nicotine itself that's vaporized versus all the chemical additives. And then as well, the flavoring additives. I think it's very difficult to kind of untangle those three things. We're certainly having a lot of discussions on how we can best measure or at least like assess the behavior use of flavoring. So we might get a better idea of like what chemicals are used in the most popular flavors. But it's a good point, and I think it's something that we can consider going forward. We're going to confirm, e-cigarette use with urine biomarkers using cotinine, but there's not one true biomarker right now for electronic cigarettes versus tobacco cigarettes. So something to think about for sure. So thank you.
It can be done in an acute manner with the impulse oscillometer or something like that, but chronic use, no one's going to want to vape if it doesn't have a good effect for them. So I mean, chronic
Exactly.
gas, but you might be able to look at it in terms of an acute stimulus situation.
Yeah, that's true. Thank you.
Looks like Dr. Musavi has his hands up. So you can go ahead and...
Yeah, so here in the UK, I believe the NHS is promoting taking up e-cigarettes as a smoking cessation tool. So I was wondering whether you'd considered another group, which would be smokers who had switched to e-cigarettes to see, I mean, you may get the increased heterogeneity in gas exchange with the e-cigarettes, but it might be less than you would get with regular smoking. We had a student project, undergraduate student project, doing a pilot study on this, because we had a whole group of smokers at the university that we were very easily able to recruit. And the problem there was matching the nicotine levels. They just weren't getting any satisfaction from the e-cigarettes, and they stopped using them. So that's going to be very tricky if you did consider using a group like that. I just thought, have you considered using that group?
It's something we've talked about, not necessarily in a consideration of a specific group, but what we will do is we will allow people to move from group to group over this longitudinal study. Like I said, it's not a cessation study, but if we observe the natural behavior of someone starting as a tobacco cigarette smoker only, and then quitting and using electronic cigarettes, they will kind of get moved. So we have a little bit of flexibility. And just to your point in general, Health Canada has taken a similar stance, but it's very vague and ambiguous of like, we don't really know what the health effects are. So maybe it's good for people who have quit. What we have been noticing in our survey data nationally and provincially is that, yes, there is a subset of people who use electronic cigarettes as a tobacco cigarette cessation tool, but we're seeing the opposite in young adults. Is they're starting with electronic cigarettes, and that might be more of a gateway into tobacco cigarette smoking. So important point, and I think it's something we'll probably have to analyze as we go and take into account.
Okay, thank you.
So we have one question in the chat from Nicolle Domnik. So following up on Dr. Davenport's comment, one, although imperfect, other chronic option might be recruiting a group with primarily exclusive oral or synthetic nicotine pouch nicotine intake history. They would have minimal exposure to carrier gas, additives, etc. And while the nicotine exposure would be no longer inhaled, there might be effects of systemic nicotine exposure on lung function, especially as concerns gas exchange measures.
Mm-hmm. Yeah, that's a good point. And I know you and I have chatted offline a little bit about this pouch thing going on in the nicotine world. We haven't considered including a small group of people who just use nicotine pouches, but we're certainly going to track the behavior of everyone in the study, assessing, if they are using nicotine pouches. And you raise an interesting point of assessing whether that can kind of directly affect lung function or if we can kind of tease out. So I'll definitely consider it and bring it back to Sonia. Something we have learned from our community focus groups that we've run with young adults and then with community organizations is that now nicotine pouches are replacing the concept of I'm using that to quit e-cigarettes now. So maybe 5 years ago, people were using vapes to quit tobacco cigarettes, and now people are using nicotine pouches to quit e-cigarettes. So it's still circular for us. We don't want anyone to be using nicotine, but it's certainly interesting. And I think we're proposing such a large project anyway, so if we can capture that, I think it would be beneficial. Thank you.
So we have time for one more question from Dr. Phillips, and then we will move on to the next presenter.
Hi, it's Rachelle. Very exciting. I think we should talk a little bit more offline, but there's there's not a lot of published physiological work in vaping yet, but I know there's a few abstracts, one from Manchester with Dr. Feisel's group, like endothelial function, and Dr. Stickland, Mike Stickland out of Alberta, which we all know, that it might not just be the small airways, there might be, a perfusion or vasculature component to this too, right? So I think as you go through this, just focus on some of like the microvasculature assessment too. Like obviously DLCO gives you a window into that, but I just wonder if there's any slightly more ambitious protocols on that side of it that you could maybe shoot for. And then obviously keeping in mind of the cloud study, which I'm sure you know well about. They're similar and they are doing CPETs. So you probably know all this though.
Yeah, no, this is good. Yeah, I mean, it's a good point. And I think a lot of the literature, like you said, is more kind of on the more basic as in like cellular level on e-cigarettes or the vasculature. And we haven't really gotten to the physiological effects yet. So something we can think about. And like I mentioned earlier, we will be using pre-full MRI at least to get kind of those images. So if we have access to an MRI machine, something we can think about. And then, the cloud study for people outside of Canada, that's a large longitudinal study happening more in central Canada, I believe, or Western Canada, looking at vaping. So we're definitely trying to align our outcomes so that it's complementary. We're going to use more multiple breath washout as our main test to assess, but certainly we want to align what we're doing with them. And the idea is that we will both inform national policy making on e-cigarette use in Canada.
All right, thank you. So we were going to move on to the last presenter, Dr. Valentina Jelinčić from KU Leuven. She will be presenting on single trial approach to measuring neural gating of respiratory sensations. So take it away.
Thank you. Can you hear me?
Yep.
Perfect. All right. 1 second, I lost something here. Okay, that's better. Hi everyone, thank you Sophie for the introduction. So today I will be presenting a project that is building on my PhD work, some of which I already presented at last year's meeting in Montreal. So let me start by introducing this key concept, so neural gating of respiratory sensation. So when you administer a respiratory stimulus, say a brief occlusion twice in a short amount of time, and then you measure the cortical response in the EEG to both stimuli, S1 and S2, you will usually find that the response to the second stimulus is blunted or gated out. And this is considered a healthy or a normal response because it protects your cortex from being overwhelmed by irrelevant respiratory stimuli. However, sometimes this suppression is reduced. And this can be a chronic reduction, such as in old age, anxiety, or COPD, or an acute reduction due to negative mood induction or dyspnea. So during my PhD, I investigated this neural gating, its changes by mood induction, and also specifically its relationships to dyspnea perception. In my PhD, I found no direct relationships between neural gating and respiratory perception, and we also did not observe any influence of mood induction on neural gating in healthy adults. And we now have a detailed overview of this and other research published in the very recent special issue on dyspnea for those who are interested. But importantly, we are kind of not ready to let this idea go. It makes sense to us that this relationship should exist, but perhaps the fact that we cannot find it has to do with how neural gating is measured. So currently, we measure neural gating using the event-related potential approach. So you take your individual trials, align them around your events, then you average them, then you identify the peaks and calculate gating as the S2 over S1 ratio. So this approach is great at amplifying signal while suppressing noise, and it allows for between-subject comparisons. However, when you average many trials together, you completely lose all within-subject variability, which can affect reliability. And there is a lot of researcher discretion in baseline correction, and then how the peaks are found, interpreted, and how the neural gating is calculated, etc. So one emerging alternative has been the time frequency approach. So here you take those exact same trials, you convert them into time frequency space, average, and then you extract power changes post each stimulus. So the strengths of this approach would be that you need fewer trials because low frequencies are very robust, and you can retain more data because baseline correction just works differently compared to ERPs. However, there are weaknesses, which is that it's a low specificity response that is just very complex to interpret, and you are still dealing with averages. So the key question we have is, what if we just didn't average? And this is the single trial approach that we are proposing. So here you extract information from each trial, be it in the time domain or the time frequency domain, and you plug them directly into statistical analysis. What this approach can do is preserve intra-individual variability, increase your precision for within-subject designs, and reduce researcher degrees of freedom because you mostly take this interpretation issue out of it. So our research questions for this project are, can we assess neural gating over single trials? And how does the single trial approach compare to classical averaging in terms of accuracy, precision, and bias? So to figure this out, we actually started from artificial EEG data. We simulated single trials, and in this visualization here, you can see that we introduced a lot of variability in terms of both the amount of noise. So you can see we have some very noisy trials and some very clean trials, but also in the strength of gating. So we have trials that have very good gating and trials that have no gating whatsoever. And for each of these combinations, we created many data sets, and then from each trial, we extracted neural gating estimates. We did this in the time frequency domain. This was very straightforward. We just extracted the power in low frequencies. Whereas in the time domain, it was a bit more complicated because here we first wavelet filtered the ERP, and then we used multiple linear regression to model the peaks in each individual trial. Importantly, for each NGRS estimate, so for each trial, we extracted 3 different statistical metrics: bias, precision, and correlation to ground truth. And so for the preliminary results, we found that both methods could successfully extract neural gating from single trials, with the time domain method being a bit more accurate, while the time frequency method was significantly more precise. Single trial methods could actually track changes in the underlying signals better than their corresponding averages, which is very interesting. However, signal-to-noise ratios strongly affected accuracy, precision, and bias. So from this, we can conclude that single trial approach may offer significant advantages for mechanistic and within subject NGRS designs. However, because signal quality is key for successful single trial estimates, this approach might stay limited to only highly controlled lab research. Now, our next steps are to figure out if our simulation can actually be improved to become more realistic and to do further tests on empirical data. So, to be continued. And with that, I thank you for your attention, and a huge thank you to my collaborators and research group. I'm happy to take any questions.
Thank you, Valentina. Again, I don't see any questions quite yet in the chat. So this is a little bit outside of my area of research, but it's pretty impressive what you're planning on doing. Oh, actually, as I'm speaking, I see Dr. Richard Schwartzstein's hand is up. So you know what? Just take it away.
Thank you. This is also a little bit beyond my area of work, but when you give different stimuli, we've talked a lot today and historically about the different stimuli for dyspnea, giving us different sensations and so forth. Can you differentiate those as well with EEG recordings?
Yes, absolutely. The reason that we are using occlusions in these types of paradigms are because they are transient, so they are very sharp, defined stimuli, and that is very good when you're doing event-related EEG designs. So you want to have a stimulus with a clear beginning, ideally a clear end, but that's less important. That is sort of sharp and immediately noticeable by the participant. Meanwhile, with stimuli such as respiratory loads, you have more of an increase, like gradual increase in perception, which is more difficult to capture by EEG, at least by event-related designs, but it can be done. And especially, I think, is interesting to do in the time frequency domain, which allows you to measure responses over a longer period of time relative
and
to
if you gave,
ERP.
just to take it one step farther, if you gave somebody hypercapnia and gradually increased their CO2, would that be distinguishable from increasing a resistive load?
That's a very good question. I have not tried it myself, but I can see how it would be the case because they are qualitatively different sensations. So I would expect the responses in the EEG to be different too.
Thank you.
We did that about 3 decades ago, Richard, in which individuals were given a increase in CO2. One of the things that changes dramatically is drive. And so drive changes both the way that the inspiratory load response occurs. And so you have kind of a mixed result. And so you can get interactions. It also changes basic state. So state change is going to be having an impact on that. And that's where I think Valentina's work is going to be very important, be able to look at individual time domains.
Great. Thank you very much.
Are there any other questions? I don't see any anything in the chat right now.
Yes, there's Devin.
Devin has his hand up. All right, take it away, Devin.
Yeah, just a quick question building on the previous discussion by Dr. Schwartzstein and Davenport. So if you did a hypercapnia test where you get the PCO2 up to say 55 millimeters and you're measuring diaphragm EMG, respiratory mechanical swings, ventilation, and you get the same respiratory mechanical load during natural unimpeded exercise. So not resistive loading, but just natural mechanical or natural exercise, thus that you get the same ventilation, maybe close to the same diaphragm EMG, inspiratory pressure, but the CO2 or the dyspnea will be much higher than the CO2. Would you be able to kind of further explain that with your approach to that? Would you be sensitive? So at a given level of mechanical load during natural exercise versus hypercapnia.
Yeah, so if I understand correctly the question, I'm not a physiologist, so I'm trying to understand. So if I understand correctly, it means like the more natural load of exercise versus these mechanically induced
exactly. Not
resistances
like
in the lab.
loading or resistive, but just
would we notice like a different?
but your ventilation gets super high and your dyspnea still does rise, at least the intensity of
Yes,
it.
I can definitely imagine that this would be the case. Especially would be interesting to look at this via single trials, because I imagine with exercise, your dyspnea increases very gradually until it reaches the peak. Whereas with mechanically induced dyspnea, you kind of have an immediate increase in perception, which then maintains or perhaps habituates over time. So I can imagine that this difference in the background perception could affect the responses that we observe.
Yeah, or the nature of the ventilatory stimuli. Yeah, interesting. Okay, thank you so much. Amazing.
Still no other hands up. I imagine that this method that you're introducing, given the high amount of variability with physiological testing within individuals, especially when you're introducing a time domain, will be really useful for us physiologists moving forward. So great work. Thank you.
I certainly hope so. I mean, it's a bit unfortunate that it seems that you really need high quality signal to get it, which sort of makes it quite difficult to transition into clinical applications. But well, there's still lots to do. So it's possible we'll get there eventually.
Is the long-term plan to have sort of like an app for us to be able to use to more easily analyze the data, the EEG data?
That would always be very nice if we would actually find evidence that this relates to dyspnea perception and that you could perhaps train it as a sort of protective mechanism. That would be great.
Great. So we have like a minute left. So if anyone has a question, please go ahead. And if not, I believe I will leave it back to Felix to wrap things up.
Yes. Thank you all.
Thank you.
Valentina, you can unshare your screen. Perfect. Okay, so I'll share. Just give me a second.
Yeah, sorry, so many windows.
Yeah.
Kind of hard to find the button.
Yeah, that's what I'm working on since this morning. A lot of different windows. Okay, so here it is. So Valentina.
I managed.
Okay. Perfect. So can you see my screen here? Yes. Okay. So before we wrap up, I'd like to take a moment to thank everyone who has been part of today. Thanks to our panelists, Dr. Ana Filipa Machado, Dr. Hannah Hudson, Dr. Devin Phillips for sharing their insights and sparking a thoughtful discussion. A very special thank you to our panel moderator, Dr. Paul Davenport. And I also like to thank our moderators, Dr. Camila Ilidi and Dr. Sophie Collins. And also a very warmful thank you to the presenters who introduced their work and put themselves out there for very nice discussions as well. So thank you a lot for your willingness to interact throughout the day. I think we had wonderful discussions. And yeah, that spirit of collaboration, supporting and challenging one another as colleagues is what makes this gathering so special. So looking ahead to tomorrow, we have another exciting program. We'll begin with Dr. Andrew Binks leading an educational outreach session Then this will be followed by 2 presentation sessions focused on the measurement and the management of dyspnea. And to close the event, we'll hear from Dr. Annemien Jonkman with a keynote lecture titled Personalizing Mechanical Ventilation to Relieve Dyspnea in the ICU, from Monitoring to Meaningful Care. So as we finish today, I encourage you to reflect on the themes and questions that resonated with you and carry those ideas forward into tomorrow's sessions and into your own work. The conversations that begin here have the potential to grow into collaborations and insight that extend beyond this event. So on behalf of the organizing team, thank you all again for your generosity, your energy and contributions. And we'll see you tomorrow. Thanks, everyone.